disclosures. I'll be talking about this title really in its component parts. So first, I'll be talking about cerebral palsy and why it's important for everyone, adult neurologists, pediatric neurologists, everybody to know what it is and to diagnose it appropriately. Then I'll be talking about dystonia, what dystonia is, and why it's particularly important to understand it in the context of cerebral palsy, not just the rare progressive etiologies that we're used to thinking of dystonia about. I'll talk about optimizing diagnosis of dystonia and how we can do that qualitatively, and also think about how we can move towards doing that quantitatively, and then why that quantitative impression of how dystonia presents clinically is critical, or at least can inform our understanding of the pathophysiology of dystonia and CP. So first, CP. This is the consensus definition for CP. It's been longstanding, was last updated in 2006, and every aspect of this definition is important, so I'm going to go through it in a bit of detail. CP is lifelong. So we think of this as a pediatric disorder, but CP lasts the entire lifespan. So it's important for both pediatric practitioners and adult practitioners to know about it. It has to involve some sort of motor component. And importantly, that motor component has to cause disability. So if you have motor abnormalities that don't cause disability, technically you do not have cerebral palsy, even if you might have other features that one would think would contribute to a CP diagnosis. That motor disability has to be non-progressive, so it can evolve and change over time, but it cannot be degenerative. And it has to be due to a disturbance. So this is intentionally vague, the word disturbance. It can be an acquired disturbance, it can be a non-acquired disturbance, but it has to occur in a specific time frame in the developing fetal or infant brain. The exact time range for this is a bit in flux. Some people say within the first year of life, some people say within the first 2 years of life, but definitely early in life, that disturbance to the brain has to have happened. The impact of CP is high. This is what drew me to it in large part in the first place. 2 in 1,000 children in the US are affected by CP. Worldwide, that number can go as high as 4 in 1,000. And just in the US, for any group of CP born in any given calendar year, that group can accrue over their lifetime $11.5 billion in medical and medical associated costs. So it is a social and medical economic imperative for us to address CP. It's also important to highlight the disparities in CP, which unfortunately we are lacking in data in, particularly in the US. Marshall and Jürgen Alsop published this beautiful study showing that CP affects almost twice as many Black children as it does white children, with all other factors accounted for. So it's important to think about this when we look at our clinics as well. Do we see twice as many Black children as white children in our CP clinics? And if not, where are those children going? So thinking about this epidemiology is important from a social justice perspective. When we think about CP as a lifespan disorder, I think pediatric neurologists are used to seeing CP quite a bit. I don't know that adult neurologists think of CP as a common issue that they see in their clinic, and maybe people with CP aren't seeing adult neurologists. But it's important to note that a huge chunk of people with CP alive today are over the age of 30 years old. I said 2 of every 1,000 people, 2 of every 1,000 children have CP. Really, it's 2 of every 1,000 people have CP. And that rate is comparable to the rate of Parkinson's disease across the population. It's 6 times the rate of MS. This is a neurologic condition that we need to pay attention to across all ages. The impact of CP across the lifespan is important for us to recognize. We published the study at this point a couple of years ago in Annals, looking at aggregate data showing that people with CP compared to age-matched people and accounting for all other risk factors, cardiovascular risk factors, et cetera, had twice the risk of stroke. They have 8 times the risk of myelopathy, particularly cervical myelopathy. They have 9 times the risk of Alzheimer's disease-related dementia. And 9% of adults with CP, having never previously had a seizure, will have new onset epilepsy. And sometimes these seizures can present as cognitive regression, more so than some maybe a perhaps more obvious motor seizure. So thinking about these neurologic issues in people with CP and surveilling for them, we argue is the neurologist's imperative. In addition to these clear-cut neurologic issues, people with CP as they age also face these other issues that can have neurologic etiologies, including a loss of mobility, chronic fatigue, and chronic pain. And each of these issues can have central etiologies, tone-based etiologies, under treatment of tone, under identification of tone-based etiologies. These things are important for us to address. And ideally, it's the neurologist that's best poised to address them. The diagnosis of CP has been recently somewhat fraught. We've demonstrated that there's variability in how we're diagnosing CP. And the way we did that is we surveyed 330 physicians who care for people with CP, including a large chunk of neurologists, but also orthopedists, developmental pediatricians, et cetera. We surveyed them across North America from 2 professional organizations, specifically looking for groups that had dedicated interest in CP. And we posed multiple hypothetical scenarios to these groups. And we asked them, would you diagnose cerebral palsy in these scenarios? So I'm going to show them here. And as I play them out, I would like for you to think, would I diagnose this hypothetical child with cerebral palsy in this scenario? So in all of these scenarios, the presenting child was a 5-year-old boy who presented with difficulty walking. In the first scenario, this child had had an MRI and had a history of prematurity. The MRI showed evidence of periventricular leukomalacia. There was no genetic cause identified in that first scenario. We described that the motor disability was not progressive, and he had increased tone. He had spasticity in both of his legs. And the majority of people in this scenario would diagnose CP. And we kind of would think of this as maybe our kid with classic spastic diplegic CP. I think it makes sense that the majority of people would diagnose CP in this scenario. In the second scenario, same sort of background, so 5-year-old child presenting with difficulty walking. All of the other features were the same. So again, prematurity, PVL, not progressive. This kid had spastic diplegia, just like the first child, but a genetic cause was identified in that child that was also associated, that could present with a very similar phenotype. In this situation, only 67% would diagnose that child with CP. And if we ask people specifically why, 40% said specifically they would not diagnose CP, typically diagnose CP in the setting of a genetic etiology. These are some quotes to explain or some rationale that was given by physicians to support this. With a specific genetic diagnosis or syndrome, this would be the more appropriate diagnosis, suggesting that this diagnosis should supersede a CP diagnosis. This quote, cerebral palsy is a bad term. Patient has a known genetic disorder. Again, suggesting that one disorder is better, or one diagnostic label is better than the other, or should have primacy. And then this quote, I guess the general neurologist would call it CP, but given my genetics training, I feel that it is too much of a bucket diagnosis. So again, highlighting that it is somehow better or indicates more expertise to be able to give a genetic diagnosis compared to a CP diagnosis. We would argue that this is perhaps a mischaracterization of a CP diagnosis. So CP is a clinical or phenotypic diagnosis. It is not etiologic, very similar to epilepsy. We don't say someone has Dravet syndrome, so they no longer have epilepsy. We say they have epilepsy due to an SCN1A mutation. Very similarly, a genetic etiology does not exclude a CP diagnosis. You can instead have CP due to X genetic condition. And the other reason this is important to think about is that many adults with CP who may hit the adult neurologist clinic likely missed the genetic revolution that's overtaking us now. So they may not know the etiology of their CP. And that may still be useful for family planning and prognostication and screening purposes for those adults. And also it's possible that a CP diagnosis may have been made in their childhood. And we know these diagnostic labels follow us around and can predispose a clinician evaluating that person with an anchoring phenomenon, like, oh, they have CP, that's their diagnosis. I don't need to think about the history of regression that's presenting in front of me. And I would love to say that we're not a subject to that sort of anchoring feeling, but I will just speak for myself and say that I know I am. So thinking about CP critically, is this the correct diagnosis? Is it, have they had progression of their underlying motor disability? That's really important, particularly when evaluating an adult with CP, to make sure that their history matches a diagnosis that may have been given to them 30, 40 years ago. When we look across the board now at the available data about genetic contributors to CP, up to 30% of people with CP may have a genetic contributor to their phenotype. And this includes people with other risk factors for CP. So even in children born premature, even in children with evidence of neonatal distress, the yield of genetic testing, even in this population, is about 8%. So don't discount a potential genetic contributor to a CP etiology just because a child was born premature. These genetic etiologies are important for us to integrate into our clinical practice, particularly in light of recent ACMG guidelines suggesting that exome and genome sequencing, if available, should be considered as first or second line testing for anybody with developmental disability. And this isn't just an intellectual flex. It's not just knowing to know. The results of this testing can change acute or long-term management in the people who are tested 8 to 10% of the time. And when we talk about changes in management, this is independent of changes in family planning, which is what we usually hang our hat on in terms of the value of genetic testing. This is with regards to, in the minority of cases, changes in treatment or disease-modifying agents. But in the majority of these cases, it changes how you think about prognosis for that particular person in front of you, and also screening recommendations for that person. So if you have a genetic condition that predisposes you to CP and also predisposes you to heart conditions, making that genetic diagnosis is valuable so that person knows to start screening for those heart conditions early and prevent that source of morbidity. So think about genetic testing not just as an intellectual exercise, but as a true change in management for the person that you're testing. We recently looked at the yield of exome versus CMA in people with CP, and we looked at the available data for this. We saw that across multiple studies, whole exome sequencing had about close to a 25% diagnostic yield, but CMA had something closer to a 5% diagnostic yield in people with CP. And based on this, we laid out recommendations, and I should say this is a study that was beautifully led by Sid Srivastava at Boston Children's. We laid out recommendations for how this testing should proceed in people with CP. And this is truly testing across the lifespan, how it should proceed if it has not been done. So doing a complete clinical evaluation, looking for what we called red flags for the possibility of a genetic disorder. And I want to highlight this particular line, the mismatch between perinatal history, MRI, and motor phenotype or severity. And we've given examples here. But again, just because a child is born in 34 weeks, if they had an unremarkable NICU course and they're presenting to you with significant motor impairment and spastic quadriplegic cerebral palsy with associated dystonia, and their NICU course was relatively unremarkable, that should make you think, what has predisposed them to this severe phenotype when their exposure, when their injury-based exposure was relatively mild? So don't be skewed. Think critically about each of these factors. We recommend doing an exome first before CMA. Now, this is hard, I know, given insurance approval. Many insurances require that you do some other sort of genetic testing first before pursuing an exome. There are many panel tests that you can do that will reflex to exome, and that has been my practice in Missouri, to think about doing these panel tests first, knowing that the exome data is collected, and that allows for that insurance approval to occur. We are hoping that insurance catches up with what should be good clinical practice, but we know that takes time. But we do recommend that the appropriate clinical practice, if it is insurance approved, is to actually do whole exome first. And then if you do not have a diagnosis, or if that exome was not associated with copy number variant analysis, to then do a CMA. And then importantly, to think about reevaluation. So genetic information accrues at a pretty rapid rate. One exome is not enough. An exome from 5 years ago is not the same exome analysis that would be done today. So we recommend using that data and thinking about reanalysis every 2 to 3 years after that exome is done, and making sure that that happens. Now, to put all of this in the lap of the neurologist, I know is a tough ask, but making sure that you're thinking about it. These people may come to you first. People with cerebral palsy may come to you first, and you may be the person that is plugging these people in with the correct genetics team, or helping get these tests ordered. Finding a geneticist or genetics experts to partner with can be really important. This can't be done as an island, but it's important to know what should be done. And because these people may often come to you early, we again are kind of gatekeepers of this information for this population. We noted I noted earlier that many physicians felt that a genetic diagnosis should supersede a CP diagnosis, that a genetic diagnosis was better. And we asked people with CP and their caregivers what they thought about that. We surveyed about 200 people across North America. 75% value knowing the cause of their CP, but 48%, only 48% had been told the cause of their CP by a medical practitioner. Again, highlighting why it's important for us to close that gap. And the majority preferred carrying a CP diagnosis together with an etiologic diagnosis. So negating the viewpoint that one diagnosis should supersede another. When we ask people what a CP diagnosis might provide them versus what an etiologic diagnosis, like a genetic diagnosis, might provide them, people noted that a CP diagnosis better provided them an understanding of the evolution of their symptoms, the ability to explain their symptoms or their child's symptoms to others, access to services, and access to a community of people with shared experiences. And we know that access to this community can lead to not just an improvement in the care of, an improvement in the quality of life of the person for CP themselves, but also an improvement in the quality of life for their caregivers. So for all of these reasons, we encourage you to give these diagnoses together. In this paper, we outlined a framework for how to do that. And I would encourage you, whenever you see someone with CP, to say CP due to X. And I think I may be preaching to the choir here, but this is an issue that is incredibly important. And if you feel like I'm preaching to the choir, I would encourage you to go out and preach to everybody else. This is a critical issue, and it's an important step for us to take to make sure people with CP are getting the diagnoses and information about their condition that they want to have. So I've talked about cerebral palsy. Next, I'll talk about dystonia specifically in cerebral palsy. Dystonia is a voluntary movement-triggered overflow muscle activation. And the way I explain this to my family is it's when whenever you try to move, a different part of your body moves without you intending it to. So even as I say that, you can imagine how functionally limiting it is. Every time you try to move, your body moves in a way it doesn't want you to. So dystonia, as you might imagine, is associated with significant functional limitations with CP. It's also arousal dependent. So it tends to go away in sleep, activated by stress, by excitement, by happiness. So these sorts of features can help us understand what dystonia triggers may be. In CP, dystonia is often painful. It's the second most common cited cause of pain, secondary to hip subluxation, typically associated with functional impairment. About 80% of people at GMFCS 4 and 5, so these are people with CP who are not independently ambulatory, 80% of those people have dystonia. And vice versa, if you have dystonia, you tend to be have greater functional impairment, have greater gross motor functional impairment. Treatments for dystonia are limited, but what we do know about it is that when we institute treatments, they may work better if we institute them early. So identifying dystonia early is important. And it is common. So in at least one study, dystonia was identified in somewhere between 75 to 80% of people with CP. To some degree, dystonia was identified specifically in the legs. So it may not be the primary or the main type of tone impairment that you see in someone with CP, but if you look for it, it's there. And chances are it is likely contributing to the functional impairment you see in the person with CP. And this is all important to note, and perhaps was most frustrating for me at the outset, because the biggest gap, I think, in treating and curing dystonia and CP today is identifying it. And identifying it is really hard, and we don't do a good job of it. And I'll move into how we've tried to optimize that next. Child neurologists and neurodevelopmentalists really see that we are that this is our wheelhouse, that identification of dystonia and differentiation between spasticity and dystonia is something that we're very good at. And it's also something that we feel is really important for cerebral palsy management. So this, again, is something that we should be focusing on as neurologists. It was rated very highly in this survey study, an advocacy study that we published in terms of importance for CP diagnosis, and also rated very highly in terms of how good are we at it? What is this? Is this a unique contribution that we can provide to the field? Yet, when we look at children at high risk for CP, and this is in our large tertiary care center, we're not doing a good job at identifying their tone types early. So by the time they're 5 years old, only 30% have the types of tone they have identified. And even more shockingly, if we look at all people with CP, or to be specific, if we look at the ambulatory children that we see in our clinic with CP, in our CP center, in any single clinic visit, only 13% of people that have leg dystonia will have any mention of leg dystonia in that clinic note. So I think there's the saying, you know, people in glass houses shouldn't throw stones. And I think we're all living in a glass house. So I think it's important to recognize that this isn't a problem of lack of physician training or lack of physician caring. It's a workflow problem to some degree, because even when you take people that are passionate about cerebral palsy and a group of movement disorders physicians that have expertise in dystonia diagnosis, we're not diagnosing it nearly as often as we should. So identifying those gaps and recognizing those weaknesses are important. The opportunity here is that identifying dystonia diagnosis or identifying dystonia early can have clear management implications. So early onset dystonia in people that present with the CP phenotype there's a higher likelihood of a CP mimic. And often those CP mimics are treatable, but need to be treated in a time-sensitive manner. And lastly, even if it's not a CP mimic that dystonia is associated with, even if that dystonia is associated with true CP, as I mentioned earlier, treating dystonia early is likely to yield better outcomes, meaning you're more likely to be able to decrease the dystonia with early treatment compared to late treatment. So identifying dystonia early and accurately is important. We asked the community, so caregivers and people directly affected by CP, in addition to researchers and clinicians, how we should attack these problems. And specifically in mind, there is treatment gaps, there are diagnostic gaps, there are pain-related gaps, and the community identified many of these issues. But really high up there, and we identified 10 gaps in total, but here in this top 5 is again, improved diagnosis and severity assessment. So I wanna highlight that this isn't just something that I'm passionate about, it's something that the field and people directly affected find important as well. When we talk about the status quo of dystonia diagnosis, this status quo is not broadly accessible. It's a group of people, movement disorders experts, reviewing videos, neurologic exam videos together, and deciding who has dystonia and who does not have dystonia. And we've all seen this. We've seen this at movement disorders conferences. We've seen it at Child Neurology Society. They're beloved sessions when this is done. And it's so integral to how we practice clinical care that movement disorder sections across the country have these as a part of their clinical practice. So we have a weekly video review as a part of our movement disorders practice. But it is a tall ask to have even one pediatric movement disorder specialist present at a center let alone 2 or 3, so you can get together and discuss videos weekly. So how do we take this group discussion gold standard and how do we generalize it to physicians across the country, to the community? How do we make dystonia diagnosis accessible? So we sought to determine exactly how, in these discussions, experts are identifying cerebral palsy. So what are they saying that is associated with the CP diagnosis? And we used qualitative content analysis, a technique called qualitative content analysis to do that. We had 3 movement disorders physicians review over 100 videos of people with CP during walking, so as they walk towards the camera. All of these people with CP also had spasticity, so we wanted to make sure that these physicians were differentiating dystonia from spasticity and not just looking at dystonia versus absence of dystonia. We had them grade dystonia on the Global Dystonia Severity Rating Scale, and notably, they only looked at dystonia in the legs. So I'll play a couple of videos here. This person on the left is a person with mild gastric spasticity, but no dystonia, and you'll see a pretty consistent regular gait. This is a child that has both hip adductor spasticity and gastric spasticity and dystonia, and you'll see a variability in their gait pattern as they walk, variable adduction specifically of these legs coming in. They had an average GDRS, Global Dystonia Rating Scale, that was high. This person had a GDRS of 0, suggesting they had no dystonia. And if we look at the specific features that experts cited, it was this variability, variable scissoring, variable adduction, limitations to function that were noted in this child with dystonia, and this consistency, consistent stride length and leg and foot posture was noted for the child without dystonia. We can quantify this across the board. So this concept of variability, we see pop up both in association with the presence of dystonia, it's the second most common cited feature, and the lack of variability is the most common cited feature, justifying the absence of dystonia. And if we look at this with regards to features experts cited with regards to severity, the effect on gait and the effect on adduction amplitude were the most commonly cited features. And you see the gait being affected, the darker the colors get, the more severe the dystonia. Gait being affected was mentioned more often with more severe dystonia. And adduction amplitude was correlated quite nicely with dystonia severity, with large adduction amplitude being associated with severe dystonia and small adduction amplitude being associated with mild dystonia. So if we look at these features, if we look at these features overall, we see that this variability, effect on function, and adduction amplitude are the key features. So when we think about that with regards to our existing rating scales, there is accounting for amplitude, and at least one of the rating scales that are validated in people with CP for detection of dystonia, but there's no accounting for variability. So this is something to keep an eye on as we're thinking about diagnosing gait dystonia in our clinic, something that can be really valuable to see. Now, when we've talked about how dystonia is currently diagnosed, this group discussion, consensus-based discussion, how can we move towards quantitative diagnosis? So what we did was we took these expert-cited features and we looked at the same videos and we tried to label the different parts of the body on these videos and quantify features that correlated with the expert-cited features. And some of this labeling is using machine learning guided pose estimation techniques, but the features themselves are informed directly from what the experts said. So we know what we can label reliably on these videos, and we looked at gait effect, variability, and adduction amplitude as features that would help inform diagnosis. We labeled and calculated a wide variety of metrics across the body that you can see laid out here. And what we found was that there were a few key features that appeared to correlate best with the presence of dystonia, which is here in blue, compared to the absence of dystonia, which is here in gray. And you see that the foot angle minimum, so how close the foot comes into midline, inter-ankle or inter-knee distance minimum, so how close the knees come together in midline. And then if we look at across other variables, specifically the variability of inter-ankle distance, so how variable the feet come in together. These were all features that were significant significantly different between people with dystonia compared to people without dystonia. And if we plot those features against the global dystonia rating scale, looking to see if there was an association with qualitative severity scores rated by experts compared to these quantitative metrics, there were two features accounting for adduction variability and adduction amplitude that had clear correlation. So what we would suggest is that these features, even though they may not be clear-cut diagnostic discriminators, can help track severity. And that can be useful for clinical trials, but it can also be useful in our own clinical practice to look at improvement following treatment. That was all lower extremity. Next, I'll show upper extremity videos. This child on the left is being asked to do this hand open close maneuver, and you see dystonia in the shoulder. You see that and I'll have it play it again. That left arm rotates in, you see the wrist flex. You'll see it similarly happen on the other side in both the shoulder and wrist, both proximal to distal involvement with that hand open close task. Here, this child, he'll do hand open close with one hand. You don't see dystonia on the other hand. And then he does hand open close on the other side, and you see overflow, that spooning of the thumb, and you see the legs extend. So overflow there to both the legs and the hands in this child. What we asked our group of experts to do for this group of videos is look at only upper extremity dystonia during a wide range of upper extremity tasks. And that includes hand open close, finger, nose, finger, grabbing a piece of paper and bringing it back to you. So a wide range of upper extremity tasks. And we asked them to describe how they identified upper extremity dystonia. What we found is that, and here oh, I'm sorry, it looks like the coloring is flipped. This lighter color here is actually the most severe dystonia. Apologies for that. So as dystonia gets more severe, the likelihood of mentioning of the shoulder or of shoulder involvement increases. As we see that we're trying to differentiate dystonia from other types of movements in people without dystonia or mild dystonia, there's a concept of mirror movement. So how do you differentiate overflow from mirror movement? And I'll show you an example of that in the next slide. And then lastly, and this is what we found most compelling and has the potential, and we argued can affect clinical practice. Of all of the upper extremity movement examination features we tried, it was this alternating hand open close task that experts felt was the best at discriminating dystonia. And they cited it the most specifically for people with mild dystonia. They felt that it was this task that allowed them to help differentiate the presence or absence of that mild dystonia. So it is a very simple task, alternating hand open close while a child is seated with their legs suspended. And I will tell you that it was not a part of my routine neurologic exam to include that task, but it is now. So it is a quick and easy task that we think can allow for the elicitation of dystonia, particularly in this population, people with CP. This is another group of people that did the hand open close task. These are all videos from Gillette Children's Hospital. And you can see here with hand open close on one side, not much overflow to the legs. But here, you do see overflow to the legs with dystonia. I'm going to skip over this video for a second and show you this video. Hand open close on one side. And as she starts doing that faster, you see those legs come in ever so slightly, slight adduction of the legs. She's going to start slow on this side. And she's going to go faster. And again, ever so subtle adduction of those legs. So it's that subtle dystonia, even of the legs, that can be elicited with that hand open close task. This child I wanted to show you because he gives you a great example of mirror movement. I've blurred his face for his privacy, but the physical therapist here is asking him to only do this one at a time, and he's saying he can't. That his other hand, by default, mirrors the voluntary movement on the other side. We see this a lot in kids with CP. It is a developmentally typical phenomenon as well, but many kids with CP, particularly those with dystonia, don't outgrow it. So making sure that you differentiate these mirror movements from dystonia is also important. When we look at leg adduction in particular, we had only looked previously at gait videos that were acquired in St. Louis. we took these seated hand open close videos acquired from Gillette, and we asked people across the country to assess them, 8 movement disorders physicians, not from Gillette and not from St. Louis, to assess these videos. And we found that very similar metrics were associated with dystonia in these videos, but with much better diagnostic discriminatory power, particularly when we look at these variability of adduction metrics. So again, blue is dystonia, gray is not dystonia. This is over 194 videos. And you see that there is a cutoff here that will give you in both of these metrics, but particularly in variance of intra-knee distance, about 95% specificity for a dystonia diagnosis. And we see that carried through in variability of adduction metrics and other parts of the leg as well. When we look at severity tracking, a looser correlation for many of these metrics than we see for gait dystonia, but still it's there, particularly for, again, variability of intra-knee distance adduction, variability of inter-ankle distance, and variability of inter-toe distance. And again, this is over 194 videos of children with CP and spasticity as we're doing this hand open close task. So the opportunity for quantitative assessment is important here and can be valuable. We hope eventually clinically, but for sure it can be valuable for clinical trial purposes. I've talked about assessing dystonia so far in people. We can also do it the same way in mice. And a large part of what drew me to all of the quantitative assessments in people was thinking about mouse-based pathophysiology of dystonia as well. So the way we currently assess dystonia in mice is during a tail suspension task with the argument that tail suspension engages the core of the mouse, and typically the legs are splayed out. So there should not be a lot of engagement of leg musculature. But in a genetic dystonia model, these limbs clasp, they clasp into midline. And the argument for that is that that's overflow muscle activation. The problem with quantifying clasping present or absent, is that it's an all or nothing response. So it doesn't give you the concept of a gradation of severity. And the other, I think, biggest problem with this is that people don't clasp. Nobody comes in with dystonia and looks like this. So using clasping specifically in the presence or absence of clasping as the marker for dystonia didn't sit right with me because that's not what we see in the clinic. So keeping that in mind, we thought to see if this adduction variability could be quantified in mouse models of dystonia to see if that could be potentially helpful for quantifying dystonia in this population. So we've done that with a group of researchers focused on genetic dystonia, and these are their videos that they recruited at UT Southwestern in Texas. And we looked at their control mice, and we looked at the distance, this adduction distance between the legs to midline. We looked at controls, and then we looked at their dystonia models. And we see that the knockouts, the mice that are dystonic, the genetic dystonia models do have increased adduction. So those legs do come closer to midline. And what we also see is that these two groups in the interim, these are groups that have had a rescue protein expressed. The knockout is a torsin 1A knockout. This group has had torsin 1B overexpressed with hopes of restoring torsin 1A function. These are control groups with torsin 1B expressed. This is a knockout with torsin 1B expressed. And as you can see, there's a gradation here. The adduction is the least in the controls, slightly more in the ones with torsin 1B expressed, more still in the knockouts with torsin 1B expressed, and perhaps the most in the knockouts without torsin 1B. And this gradation, seeing this difference, is not apparent when quantifying clasping alone, but is apparent when we think about using clinical metrics to quantify what is and is not dystonia. And why is this important? It's important because when we think about how we develop treatments, we use animal models and we use an understanding of pathophysiology from animal models to do that. So if we're not looking at the true clinical phenomenon in a mouse model of disease, we slightly decrease the chances that that treatment will eventually apply to us and will apply to the people that we care for. So a huge push in my lab is thinking about the clinical phenomenon of dystonia and how to translate that true clinical phenomenon to mice. So I'll stop here. Thank you so much for inviting me today, and I look forward to taking questions from all of you.
Thank you so much, Dr. Aravamuthan. I think it was a very interesting and new ideas, I mean, that you shared with us. I mean, I personally learned a lot. So we open the session for questions.
Can I go first?
Sure.
Hi,
First
Dr.
of all,
Giddy.
hi, Bhooma, wonderful talk, and as always, and this is something that I have struggled from the time I was a junior, pediatric neurologist, and you are now, your group, you are articulating beautifully of, bringing us to understand that CP is not in isolation, just as we say, epilepsy is not in isolation. So that's a very good example that's saying, hey, patient with Dravet can have epilepsy and they're not mutually exclusive. Similarly, we have to again take the next step of saying, yes, this is a CP due to a known genetic disorder, mutation, and so on. So I had always emphasized to my trainees that CP, watch out for that diagnosis, because there are a lot of genetic diseases that are missed because we have given it a label. So I'm very happy to see that. And not only clinical, but you're also moving the field forward in, of saying, hey, there are so many bench, work that can help us understand the pathophysiology. So couldn't be prouder of you and your work. And so good luck and continue to teach all of us.
Thanks, Dr. Giddy, for those
Okay.
kind words and your
Okay.
advice and mentorship over the years. I appreciate it.
Okay. Take care.
Okay, I have a quick question too. So it was very interesting, the software analysis that you showed in your research. Do you see this coming out as an application perhaps that you can use in practice to like record the patients and that just get the analysis results?
Yeah, I do. I think we're a ways from that, but I think it's very possible that we'll get there soon. The goal is to obviously have a phone app. So all of these videos were recorded on iPads. We're recording videos now in Google Pixels. This technology is easily available. The hope is that you can find an app that not just a physician could use theoretically, but that you could give permission for your families to use at home, to be able to record a video at home of their child walking or their child sitting and doing a certain task. And then for that analysis to be able to be done, and then give you a likelihood of dystonia in that person. Most likely it's going to be that in combination with a series of other things. There's other data that we have looking at caregiver focused screeners for dystonia and CP. And I think taking all of that into combination, that is the future. And I don't think it's as far away as we think it is. It's still out there, but it will come. I think within our lifetime, it'll be there.
It's very interesting. Thank you. So, I think there is a question in the chat that I think it was sent directly to me. And it says, on patients with CP transitioning to or coming as a first-time patient to adult neurology, what are some of the things that the clinician should be thinking about or asking about?
Oh, great question. Okay, so I will put in a plug for this paper. We wrote out kind of a cheat sheet for things that should be screened for an adult with CP that's seen in an adult neurology clinic. The things to make sure you have are an up-to-date or a somewhat recent brain MRI, so brain MRI done in adulthood. The imaging that was done for a lot of adults with CP tends to be old or inaccessible. So having a baseline brain MRI can be really useful because of the risk of stroke and other accumulated neurologic deficits that you're at higher risk for in life as an adult with CP. Clearly documenting the baseline exam and the motor phenotypes associated with that baseline exam is important, and then looking for regression or changes in tone, particularly increased spasticity of the lower extremities and weakness in the hands. That cervical myelopathy goes unnoticed very often in adults with CP, and a part of that is just because, oh, it's your CP, you know, yeah, you're not walking as well, like that's what happens. But being vigilant for that is important also. And then I would say making sure that you're asking screening questions about epilepsy and cognitive decline is really important too. So making sure that all of that is done on every visit in a surveillance fashion. I'm not saying get screening EEGs on everybody with CP, but if there's evidence of cognitive decline, then I think it is very important to get that EEG, because the risk of epilepsy is quite high in this population. So making sure you're not missing that. And then lastly, thinking about what medications they're on and what medications they actually need to be on. We all see this, I'm sure adult epileptologists see this all the time. This person has been on phenytoin for, I don't know, 15 years. They don't want to come off the phenytoin. It's helping their seizures, but your heart breaks for all the side effects they're facing. There's a good population of people with CP that may be able to come off the AEDs they've been on for a lifetime. So thinking about that critically is also valuable, and thinking about how you can reduce that polypharmacy that's been carried with them for decades can be valuable too. But I'll put a link to the chat for that paper. It includes a table with a cheat sheet for kind of a key for what we would hope both the adult neurologist and the person with CP is aware of about neurologic manifestations of CP as you age.
That would be great. Thank you.
Yeah.
There's 2 more questions in the chat. So from Pete's Neurology and then Danny. So they said, Pete's Neurology, would you be able to give us a brief overview about the question?
A brief overview, sure. Treatment of dystonia is a bit fraught because we don't have a lot of evidence-based guidelines for how we treat dystonia. There's a new AACPDM, American Academy of Cerebral Palsy and Developmental Medicine, dystonia care pathway coming out. The existing one is a little bit out of date, but I'll tell you what the updated care pathway is likely to reflect. First-line treatment for dystonia and CP is either baclofen or benzos, which might be what you would already use to treat spasticity. Baclofen can be very useful for this purpose. We try to get people on clobazam if at all possible. There's an insurance hurdle there too, but it's a less sedating benzo that we try. Second and third line. So now this is where it's a little bit unclear. The data for artane, trihexyphenidyl, and cerebral palsy is not good, meaning not that it doesn't exist, but the data that exists suggests that it doesn't work. So the data that we have for trihexyphenidyl in people with CP suggests that it's the biggest outcome for it is increased side effects. Now, we all have stories of artane working for some person that we've seen with dystonia. It is, I think, more likely to work for dystonia associated, for progressive dystonia associated with the conditions that cause that, than it is a non-progressive dystonia in the context of CP, and the data supports that. Have I never tried artane or trihexyphenidyl in someone with CP? No, but I won't do it first or second line because of that data that exists. So I just want to address that, a bit of an elephant in the room there. So after baclofen benzos, next I will choose between actually clonidine and gabapentin. Not a lot of great data to support either of those medications, but the data that exists suggests that it can help with dystonia and CP. Gabapentin in particular, up to 18 milligrams per kilogram per day or higher, can be helpful, particularly for dystonia in people that have associated sensory issues that can trigger the dystonia. So pain-triggered dystonia, or I don't know where my arm is in space, and also I have dystonia in that arm, that can be helpful. Clonidine is really helpful in kids that have a lot of mood instability or really sleep problems, making sure that you optimize sleep. Clonidine can help with that, and maybe as a side effect also helps with the dystonia. But I tend to give clonidine to kids who aren't sleeping well, who also have dystonia. And with all of that in mind, you can't treat the dystonia if the triggers still exist. So if a kid is really anxious and a kid is not sleeping well, and a kid has a really painful feeding paradigm, that dystonia is going to stick around. And no matter how much clobazam or how much, baclofen you put that kid on, or clonidine or whatever you put that kid on, if you're not addressing the triggers, that dystonia is not going to go away. So assessing triggers, including thinking about psych medications like SSRIs or SNRIs for anxiety-based treatments, can also be helpful, particularly in our older kids with dystonia. So sorry, this is not as brief as I would have hoped. So that's pharmacologic. Botox, I am wary of for a lot of kids with dystonia, because often it's either dystonia or flaccidity in the affected limb. But if someone has true mixed spasticity and dystonia in a limb, and it's a focal dystonia, Botox can be helpful. And last, surgical referrals. So there's deep brain stimulation of the globus pallidus, pars interna. And there's a lot of data for high C-spine intrathecal baclofen, the idea that baclofen infuses into the brain and that's what treats dystonia. A lot of the availability for the surgical treatments is center dependent. We have not done high C-spine baclofen, at least in recent memory at WashU, but we do have a DBS program. And the candidacy for the surgical treatments is typically, you haven't done well on a few meds, Botox is not an option, or you haven't done well on Botox, let's think about surgical treatments for you. So that's as brief as I could get, sorry.
That was great. Thank you so much. And there's one more question in terms of whole genome and whole exome. Have you had retested patients and had new information?
Yeah, so there's a difference between retesting and reanalyzing. And so I just want to make that clear. And so once you have the whole exome data, the genotype data is available. Or the exome data, or the whole genome sequencing data. Once you have the data, that data, as long as it was acquired with good fidelity, which in the last 5 to 6 years it will have been, that data is good. The issue that we need to make sure of updating is reanalysis. So when we think about getting whole exome, they're only analyzing it based on the available knowledge of the genetic disorders that are available, and what we provide is the phenotype. So if we get more information about the phenotype, then immediately I'll ask for reanalysis. If I find out something new about someone's phenotype, their MRI has a very specific pattern, their motor phenotype was not included in the last whole exome analysis request, even if it hasn't been 2 or 3 years, I'll ask for a reanalysis with that new information, because sometimes that'll pull up a diagnosis, and that's happened to me before. But regardless, even if nothing has changed, every 2 to 3 years you get a reanalysis, because what we know about the genetic disorders that are out there change in real time. So every 2 to 3 years is a recommendation for reanalysis. But you don't have to retest. It's not like you have to get another blood test or another cheek swab. You can use the same data, but you just ask the company to reanalyze.
Thank you. Any more questions? I think we are done with the time also. Thank you so much, Dr. Aravamuthan. It was an amazing talk, and we all learned from you. So thanks.
Thank you, and thank you for having me. Happy New Year.
You too. Thank you.